Good evening, everyone. Welcome to the today's session of physiology lectures. Today, we are targeting the topic of blood physiology, hematology, and as you know, that this lecture series is targeted mainly towards the UG students to help them to recapitulate and have an overview about the topics. By no means, these lecture series, these classes in this lecture series is not going to replace the regular teaching procedure, teaching process, but it is going to supplement the teaching what is going on in your classes. So if you want to recapitulate, if you want to get a little extra or overview or some other way of presentation that may help you in understanding the topics. This lecture series is being organized by the Education Committee, the Physiological Society of India. It's a monthly endeavor every month, fourth Saturday, 7 to 9 evening. We arrange this broadcast. This this broadcast is also being available in the offline, not offline, it's like off time in the YouTube. So anyone can go through these videos afterwards also. Not necessarily have to live only. Live it is always good. If you have any query, if you want to interact with the speaker, you can. Today we have Dr. Tanushree Samanta. She is Associate Professor and Head, PG Department of Physiology, Raja Narendra Lal Khan Women's College, Autonomous, Midnapore, West Bengal. She did her graduation and post-graduation from Vidyasagar University, and then she did completed her PhD from IIT Kharagpur. Currently, as I have already mentioned, she is working as associate professor and head in the Department of Physiology, is a postgraduate Department of Physiology. She has quite good number of awards in her credit. She has scholarship from Education Directorate, Government of West Bengal, as well as gold medal from Vidyasagar University for both undergraduate as well as postgraduate. She has already have good number of publications, book chapters, and also attended many courses, training courses, workshop, refreshers. She is currently guiding some MPhil and PhD students. Already had some lake projects, sponsored projects she had completed. She will be discussing today about the blood physiology. It's a, as you know, it's a huge topic. She she will try to cover the whole part as much as possible. As you understand, it's a very big topic. So almost an hour, and she will be always available. She is you if you have any query, you can contact her by chatting on your comment level. If you give comments, that question will be presented to her, and we can she will be answering those queries if you have any, or she is sharing her email ID also. So if you have any query afterwards, that also you can post her. So, welcome, Dr. Samanta,
Yeah,
and
thank you.
stage is yours.
Yeah,
Please uh, continue.
thank you, Dr. Naik, for your humble words. Good evening, everybody. So, as here Dr. Naik has already told that I'll be discussing the physiology of blood and blood cells, and as it is a huge syllabi to be covered, I'll try my level best to go as much as I can. Hope my screen is shared. Dr. Naik, my screen is shared, I hope.
Yes, the screen is visible.
Okay, thank you. So, to start with, I'll be discussing the topic physiology of blood and blood cells today. To go for an introduction, we all know that blood is nothing but a red fluid which fills up the cardiovascular system. The fluid in it, the liquid in it, is called plasma. It has got a cellular part too. The cells which comprises blood is RBC, WBC, and platelets. We also know them as erythrocytes, leukocytes, and thrombocytes. The functions of the blood majorly is known to be transportation of O2 to the tissues and CO2 back from the tissues to the lungs, which is a helping procedure in the respiration. It also distributes the nutrients. It helps in transporting waste materials to the organs for excretion. It is a transport medium for hormones, chemicals, essential elements, vitamins, etc. It maintains the acid base balance of the body, helps in the maintenance of body temperature, provides immunity in the form of antibodies and immunocompetent cells. It also acts as the storehouse of various materials, and lastly, it helps in the role of hemostasis. To discuss the blood volume, the adult male has about 5 liters of it, whereas the females have 4.5 liters. This blood volume can be determined by measuring the volume of plasma and the cells separately. When we take up the cell volume, we actually consider only the RBCs and not the WBCs and platelets. It is only because WBCs and platelets are a very small fraction of the total cell volume. The determination of plasma volume can be done by various techniques, but the most common technique being the dye dilution technique, and the dyes which are used are Evans blue, Congo red, etc. To define certain definitions regarding blood volume, the effective blood volume is the volume from which the sequestered volume of the blood is minus from the whole volume of blood. And there are various changes in this blood volume. It might be due to pathological reasons, and even due to certain physiological reasons there are variations in the blood volume. Hence it is important to maintain the blood volume, and that is done by the absorption of fluid from the gut, exchange of blood between the blood and the other fluid compartments, and by the urine output. To summarize the properties of the blood, we can say that it is an alkaline fluid with a pH of about 7.4, and as has been already told, that it's red in color and has a specific gravity of about 1055 at a temperature of about 15 degrees centigrade. The hence, the plasma can be divided into two parts, that is the water and solid, water being 92% and solid 8%. Solid can again be divided into inorganic and organic components. The inorganic is accounted to anions and cations, and the organic to colloids and crystalloids. These colloids are nothing but plasma proteins and plasma lipids, and the crystalloids are these certain biomolecules. Plasma can be separated from the blood by using any anticoagulant and just centrifuging the blood. It isn't to be mistaken with the serum, which is obtained only when the blood is allowed to coagulate. The straw-colored fluid which strews out is the serum. So serum is the plasma which doesn't have the fibrinogen or the other factors which are needed for coagulation. As has been told earlier, that these crystalloids are the ones which can pass through the capillary wall, but the colloids are trapped inside. They cannot leave easily. And these colloids are formed by the plasma proteins and the plasma lipids. Plasma lipids here we'll summarize as VLDL, LDL, HDL, chylomicrons, which and some forms of lipoproteins too. To go into the details of the plasma proteins that can be separated by many methods, two have been mentioned over here. One is the salt separation and the other is the paper electrophoresis. If we go into the plasma proteins, we'll find that majorly two things are present, that is albumin and globulin. This globulin again has a division of subtypes, which are alpha, beta, and gamma, and they again have subtypes as alpha 1, beta 1, alpha 1, alpha 2, beta 1, and beta 2. To describe these plasma proteins, the total amount of plasma protein is about 6 to 8 gram percent, in which the albumin is about 4.7 to 5.7 gram percent and globulin about 1.3 to 2.5 gram percent. The ratio amounting to about 1.7 is to 1. Fibrinogen comprises of about 0.2 to 0.4 gram percent and prothrombin is about 0.1 gram percent. So the major components of these plasma proteins being albumin, globulins, fibrinogen, and prothrombin. And this albumin is a ellipsoid particle which is about 69,000 in molecular weight, and it is being continuously produced by the liver. It has a half-life of about 19 days, and it plays a very important role in maintaining the osmotic tension of the plasma. Whereas the globulins, they are elongated shaped substances which has a molecular weight of about 90,000 to 1,56,000 and has been told earlier that it has got divisions, it has got types or groups. And I would like to add over here that the immunoglobulins or the antibodies, they are these globulins, they comprises of this portion. Fibrinogen also are elongated particles which has a molecular weight of about 3,40,000, and it is important for blood coagulation, plays a major role in the viscosity of plasma, and is again produced by the liver. Prothrombin, it is a globulin and it is important for the coagulation. Okay. Now we'll go into another topic, that is plasmapheresis. It is an experiment which is mainly used to study the rate of regeneration of plasma proteins. Other than this, plasmapheresis or this plasma exchange, it is also a tool to remove the harmful autoantibodies in various autoimmune diseases like myasthenia gravis, Goodpasture syndrome, etc. Now, the origin of these plasma proteins, as has been told earlier, that it is by the liver and also from RE cells and plasma cells. Okay. And other than these proteins, there are C-reactive proteins, which is again another important parameter, but is found mainly in the acute injury or infection. The functions of plasma proteins are to maintain the osmotic tension. It helps in transportation. Fibrinogen, prothrombin, and many other such proteins are responsible for the coagulation of blood. It is also a good buffer. It helps in maintenance of the viscosity of the plasma. The Rolex formation role of plasma proteins gives rise to the erythrocyte sedimentation rate, or the ESR, as we know. They act as the protein stores for the tissues. Antibodies are nothing but gamma globulins. And lastly, they also help in the formation of the lipoproteins. To go into the details of the blood cells, we'll take into account first the RBCs or the erythrocytes. RBCs, the full form being red blood corpuscles. Its amount is about 4 to 5.5 million per cubic millimeter. Its morphology is non-nucleated. They are biconcave. This biconcave shape of erythrocytes helps it in quick gaseous exchange. This gives a high surface to volume ratio and provides it flexibility and hence an ability to fold and pass through the narrow capillaries. But here, as because it is non-nucleated, a mature red cell can never divide. It has a lifespan of about 90 to 120 days. And the pigment, the most important thing which is present in the RBC is the hemoglobin, which makes the blood red. A normal RBC with a size of about 87 cubic microns is a normocyte. When the volume is more than that, that is macrocytosis, and less than that is microcytosis. Poikilocytosis means when the red cells have different shapes. Anisocytosis when there is an iron deficiency in it. Red cells, if they do not have the biconcave shape and are having a spherical ones, they are termed as spherocytosis. And reticulocyte is the stage just before the matured RBC. And when this count sometimes increases, then that is termed as reticulocyte crisis. To go into the structure and metabolism of RBCs, the RBC membrane is made up of proteins and lipids, as all membranes are. And these proteins, they actually form the receptors or the antigens. The blood group, which we commonly know, is because of the antigens which are present on the membrane, and they are all glycoprotein in nature. There are proteins on the inner surface of the membrane as well, and they form the cytoskeleton. They are ankyrin, actin, spectrin, red cells with the pigment hemoglobin, but there is no nuclei, there is no mitochondria, and there are no ribosomes. So this says that there will be no synthesis of proteins and lipids. There are enzymes for glycolysis, but there are no enzymes for TCA cycle. To go into the functions of the RBCs, it helps in gas transport, acid-base balance, formation of bilirubin, and plays a role in the viscosity of the whole blood. Breaking or lysis of these erythrocytes is only termed as hemolysis, and it has a tendency to hemolyze. So the RBCs are fragile. Now we'll go into again an important topic, that is erythrocyte sedimentation rate, or ESR. If the blood is allowed to stand in a narrow vertical tube, we will find that the cells will be settling down easily, leaving behind the clear plasma above. The rate of this sedimentation of the cells is only expressed in mm per hour and is the ESR. This ESR again increases in various physiological conditions like pregnancy, menstruation, or after meals. There is also a rise in ESR in various diseases like tuberculosis. ESR decreases in conditions like polycythemia, sickle cell anemia, etc., in conditions where viscosity increases. As because we have been talking about the pigment hemoglobin for a long time, now it's necessary to discuss a little bit about hemoglobin. So this is a conjugated protein which is present in the RBC and has a unique property of combining with the oxygen reversibly. When we go into the discussion with hemoglobin, now again, we have to go into another topic, which is iron metabolism, because Fe+2, ferrous state of iron, is an important component of hemoglobin. This iron is needed for the synthesis of hemoglobin, myoglobin, cytochrome, etc. Source of this iron being diet, but it is also obtained from recycling within the body, that is from the dead RBCs. The daily requirement for males for this iron is about 1 mg, whereas for females is more than that of 1 mg, because there is a loss of iron during the menstruation. This iron is absorbed mainly from the upper part of the small intestine, and that is done in the ferrous state. And iron is stored in the RE cells as ferritin. Excess of it causes hemosiderin. It is transported by another protein. Transportation happens with transferrins. Its uses, as we all know, as because it is in the composition of HB, that is hemoglobin, and cytochrome, or in myoglobin, all in Nissin granules, its mainly role is O2 carriage. To measure the iron, actually it is very difficult to measure the ferrous state of iron. So mainly what is measured is the transferrin amount or the ferritin amount, and that gives you an idea of the body iron status. Iron is mainly lost through feces and through menstruation in case of females. Now, if you go into the flowchart of the synthesis of hemoglobin, you will find that there are two different pathways which are combining together to give rise to the hemoglobin. One is, it starts with the succinyl CoA, which combines with glycine to give you alpha amino beta ketoadipic acid, which in presence of ALA synthetase will give you delta amino levulinic acid, that is converted to porphobilinogen 3, then to protoporphyrin 9, and this taking up the Fe will give you the heme portion. And from other side, protein synthesis gives rise to globin. This globin and heme comes together, conjugated, and gives you the hemoglobin. And the factors which are hence necessary for this hemoglobin formation are the first class proteins and the amino acids from which globin is obtained, iron for the formation of the heme part, copper, cobalt, and nickel for the absorption and utilization of the iron during hemoglobin synthesis. And there are certain vitamins which also helps or plays a role in hemoglobin synthesis, as for example, vitamin C, riboflavin, nicotinic acid, and pyridoxine. This is the structure of the hemoglobin, which you see here. It is a metalloporphyrin where you can see the iron in the ferrous state, which is connected to 4 nitrogen molecules in the imidazole groups of for the pyrrole rings, and it is also connected to nitrogens in the imidazole groups of the histidine residues of the globin chains. One heme and one globin chain comprises one subunit of hemoglobin, and 4 such subunits are present in the hemoglobin. So this one subunit will bind to one molecule of O2, and hence one hemoglobin is capable of binding to 4 hemoglobin molecules. Here I can add up that when hemoglobin binds to oxygen, you have got 2 states. One is called the relaxed state and the other is the taut state, R state or T state. It is when with or without the oxygen. Okay. To classify hemoglobin, the normal adult hemoglobin HbA, it has the 2 types of chains, that is alpha and beta. Alpha chains are made up of 141 amino acids, whereas beta chains are made up of 146 amino acids. Glycosylated hemoglobin is present in diabetic patients where a glucose is bound to the beta chain. A very small portion of hemoglobin in adults has beta chain replaced by delta chain, that is termed as HbA2. And HbF is the fetal hemoglobin, which is present in the fetus or the newborn, and here the gamma chain is found to replace the beta chain. The HbF has a greater affinity for oxygen in comparison to the HbA. To go into the compounds of the hemoglobin which it forms, we have oxyhemoglobin, which it binds to oxygen, methemoglobin when the ferrous state is oxidized to its ferric state, carboxyhemoglobin during the CO2 transportation, and carbohemoglobin when the CO2 doesn't combine to the heme, but it is bound to the globin portion and they form the carbino compounds. We have sulfur hemoglobin when it binds to H2S. We have hematins, acid hematins, and alkali hematins too. And we have hemine crystals. These hemine crystals plays a very important role when we want to determine the species from the blood which is obtained at a particular place. Then we go for these hemine crystals. Human blood gives rhombus-shaped hemine crystals. This can be formed by boiling hemoglobin with NaCl and glacial acetic acid. We'll go into now some red cell indices, as for example, the red cell count. This is the number of red cells which is present in unit volume of whole blood. This can be measured by the Newber's chamber. Male have 5.5 million per cubic mm and female have 4.8 million per cubic mm of RBCs. The hemoglobin concentration can again be measured in 100 ml of the whole blood, and it is expressed in grams per percentage. The most common instrument which we use is Salil's hemoglobinometer. Male have about 14 to 17 gram percent and female have about 12 to 16 gram percent. The hematocrit value, which is also known as the packed cell volume, this is the volume of the RBC in whole blood and is expressed in percentages. MCV, it is a volume of RBCs in 100 ml of blood, that is PCV, packed cell volume, divided by the number of RBCs in 100 ml of blood. MCH, it is the hemoglobin present in 100 ml of blood divided by the number of cells present in 100 ml of blood. MCHC is the amount of hemoglobin divided by the volume of RBCs containing the hemoglobin into 100, as because it is expressed in percentage. Color index, it is hemoglobin content in percent of normal divided by the RBC count in percent of the normal. We were talking about erythrocytes, that is RBCs, and this is the method by which the RBCs are produced, that is erythropoiesis. Hemopoiesis is the process of origin, development, and maturation of all blood cells. And erythropoiesis is the process which discusses the origin, development, and maturation of the erythrocytes. The site for erythropoiesis, in case of fetal life, it differs in different periods. See here, it is shown already that a fetus of about 0 to 2 months, the erythropoiesis happens in yolk sac. 2 to 7 months, it is in liver and spleen. 5 to 9 months, it is in bone marrows. And in infants, it's in bone marrow. And practically, that is in all bones. To go into the flow chart of this erythropoiesis, here you can see that this till late normoblast, it happens within the bone marrow. See, you have the pluripotent hematopoietic stem cells, which is converted to the proerythroblast, and then to erythroblast, and finally to the reticulocyte. This reticulocyte comes out of the bone marrow and is present in the blood as the matured erythrocytes or RBCs. The main thing is that before it comes out into the blood, it loses the nucleus and some organelles, and the matured one has no organelles in it at all. So if you go into the discussion of the stages, we will see that the first stage being the proerythroblast, where the size is too big, and hence it is also termed as the megaloblast. And here they have two or more nucleoli, and the chromatin network is also present. Hemoglobin is absent over here. Then we go into the next stage, that is early normoblast, which becomes smaller than the proerythroblast. There is a condensation in the chromatin network, but still hemoglobin hasn't appeared. Now we'll go into the intermediate normoblast, where the chromatin again shows further condensation, the cell size decreases, and now it is marked by the appearance of the hemoglobin. In the late normoblast, the nucleus is completely lost, and the process by which it is lost, that is, it disintegrates and it is excluded out of the cell, it disappears in a process which is termed as pycnosis. Finally, this late normoblast is converted to the reticulocyte, and from reticulocyte, it goes into the matured RBCs, which is of about 7.2 microns. And it takes about 7 days to come from the proerythroblast to the matured RBCs. These are the general factors which affect erythropoiesis. You have got erythropoietin, thyroxine, certain growth factors, and vitamins. Erythropoietin is a hormone which is secreted from the kidney, and it mainly promotes the production of the colony forming units of the erythrocytes in the bone marrow. It also helps in the development of the proerythroblasts into the RBCs, and then releases the matured RBCs into the blood. Thyroxine, we all know, is a metabolic hormone, and it accelerates the erythropoiesis method. Hemopoietic growth factors, here they include certain growth inducers, which are interleukins like 3, 6, and 11. They mainly induce the proliferation of the pluripotent stem cells. And vitamins A, B, C, D, and E are all necessary for erythropoiesis. It has been found that deficiency of these vitamins give rise to anemia. The maturation factors which have been discussed over here are vitamin B12, intrinsic factor of Castle, and folic acid. Vitamin B12 is also termed as the extrinsic factor, and this helps in the synthesis of DNA, cell division, and maturation of the RBCs. And this can be absorbed only when this intrinsic factor of Castle is present. So these two are interlinked, and folic acid again helps in the synthesis of DNA. After a long discussion on the RBCs, we'll go into another set of cells which are present in the blood, though their amount is much less in comparison to that RBCs, but they are the microscopic policemen of our body, of our system. They are the immunocompetent cells, or the leukocytes, as they are termed as, or white blood cells. The name only shows that they are colorless because they do not have hemoglobin. Their amount is about 6,000 to 8,000 mm in 1 ml of blood, and they are termed as scavengers or microscopic policemen, as I told. These WBCs mainly can be classified into two, that is granulocytes and agranulocytes. And then again, these granulocytes can be divided into three, that is eosinophil, neutrophil, and basophil, and agranulocytes into monocytes and lymphocytes. So ultimately, we get 5 types of WBCs, and this division is on the basis of the presence or absence of the granules and some of their staining characteristics. Okay. So see, this is the division which I was talking about. Granulocytes are those who have granules, and agranulocytes are those which do not have granules. So if we discuss each of the cell individually, neutrophils, they stain purple with neutral dyes. Their granules are small, numerous, and they have a coarse appearance. Their lobes vary from 2 to 7. It depends upon the age of the cell, that is age of the neutrophil. It comprises of about 65% of the total WBC count. They are highly mobile, very active. They exhibit diapedesis, that is, they can leave the blood vessels and enter the tissue space. They have a character of phagocytosis, and they contain several lysosomes which are important for digesting the material which they have phagocytosed. As because I don't have much time, I will not go into the detailings of phagocytosis and all. And I'll go into eosinophils, which are large, but they have granules which are much coarser, and they have nuclei which has got 2 lobes, and it comprises of about 2 to 5% of WBC count, and it is found mainly in the lining of the respiratory and digestive tracts. It has important functions, which is protection against the infections caused by parasitic worms or in allergic reactions. They secrete various anti-inflammatory substances in various allergic reactions. We go into basophils, which are very less in number, about 0.5 to 1%. And it also exhibits diapedesis, and it has got granules, but here the granules are mainly that of histamine, serotonin, and heparin, which are inflammatory chemicals. They are released mainly in type 1 hypersensitivity reactions when, IgE comes and binds to its FC receptors present on the membrane of the basophils. Again, not going into the details. We go into the lymphocytes, which are the smallest WBCs we have. It has got a large nuclei and a very small amount of cytoplasmic lining. It accounts for about 25% of the WBC count. These lymphocytes again are of 2 types. This division, this name is again, you can name it as small lymphocytes and large lymphocytes, or T lymphocytes and B lymphocytes respectively. These T lymphocytes are concerned with the CMI, that is cell-mediated immunity, and B lymphocytes are concerned with the humoral immunity, that is by the production of the antibodies against certain specific antigens, or rather non-self substances. We have got monocytes, which are the largest WBCs. They have a dark kidney bean-shaped nuclei, and they are highly phagocytic. These monocytes, only when it enters the tissues, they are termed as the macrophages. These macrophages again have an important role of APCs, that is antigen presenting cells, which presents the antigens or the non-self proteins with another protein called MHC, and it goes into T cell activation and then to B cell activation and all. Now we go into the WBC numbers. These WBC numbers are very important because they are the indication of some kind of infection where your surgery or some treatment might be needed. So clinics will count the number of WBCs in the blood sample by a method called differential count. If there is a decrease in the white blood cells, it is termed as leukopenia, and an increase in it is termed as leukocytosis. This formation of WBCs also happens in red marrow of many bones, and its maturation happens in various lymphatic tissues. It has a lifespan of about 13 to 120 days. To go into this figure, see, you can see this is the stem cell, which this is your erythropoiesis, which we discussed earlier, proerythroblast and early erythroblast and all till the matured RBC. And here you can find that this stem cell gives rise to myoblast, which gives a progranulocyte. And from this progranulocyte, ultimately, you get those 3 granulocytes, that is basophil, eosinophil, and neutrophil. On the other hand, it also gives rise to the lymphoblast, which gives rise to the lymphocytes, and the monoblast, which gives rise to the monocyte. These two comprises the agranulocytes. So this is the total formation of your WBCs. And here you have megakaryoblast, which I'll be coming a little later, which gives rise to megakaryocyte. And finally, we get the smallest components here, which are the platelets. To summarize the WBCs, so neutrophils are about 60 to 70% of the total WBC. It has got lobes, and its most important function is phagocytosis. Eosinophils 2 to 4%, nucleus is bilobed. It has a role in allergic reactions. Basophils less than 1%. It is also a bilobed nuclei and it has a function in inflammation. Lymphocytes, both B cells and T cells, comprises of about 20 to 25%. They are purple staining dense, round nucleus, little cytoplasm, and they are the important cells of the immune system, both by CMI and HI. And monocytes, they comprises of about 4 to 8% of the total volume. They are the largest leukocyte, and they transform into macrophages, has a phagocytic activity and function as APCs. We finally reach to the last discussion of today's session, is that hemostasis, in which this name only can be divided into two portions, and hem means blood and stasis means to stop. So this is a method in which you stop the loss of blood. So this is a process of forming of clots in the wall of the damaged blood vessels, which prevents the blood loss. Okay, so defects in hemostasis might cause a risk of increased bleeding, which is termed of hemorrhage. Okay, now the events which happens in hemostasis are vascular constriction, where the damaged blood vessels constrict. There is a formation of platelet plug, where the platelets adhere to the damaged portion and they form a platelet plug. This is termed as the primary hemostasis. And then it goes into the secondary hemostasis, which we commonly known as the process of blood coagulation, which is a cascade system in which one protein activates the another protein, and finally we come into the conversion of fibrinogen to fibrin, which is an additional clot to the platelet plug, which is formed in the primary hemostasis. So you can summarize the stages of hemostasis as the stages of primary hemostasis, which is compiled with platelet adhesion, platelet activation, and platelet aggregation. Secondary hemostasis, which is the formation of the blood clot, in which you have a cascade of reactions, a number of inactive enzymes are activated, and these activated enzymes again in turn activate another set of inactive enzymes. So this is the summary of the clotting mechanism, which you can see the factors. It comes into factor 10, and then the prothrombin is converted to thrombin, and here the fibrinogen is converted to the fibrin finally. The fibrinolytic phase, actually, this system, this does not allow the fibrin clot to grow and block the vessel completely. Okay, because if the vessel is blocked, then it will give rise to serious complications. There is a dissolution of a clot, which is called fibrinolysis. That is a process in which the fibrin fibers are dissolved, and it is brought about by the formation of an active enzyme called plasmin from plasminogen. This hemostasis process depends upon the vessel wall integrity, adequate number of platelets, proper functioning of the platelets, adequate levels of clotting factors, and proper function of fibrinolytic pathway. So what causes these bleeding disorders? If we have any vessel defects, if we have platelet disorders, if we have factor deficiencies. To have these function tests, mainly the two most common function tests which we do are bleeding time and clotting time. Other than these two, we can also go into prothrombin time, partial prothrombin time, and thrombin time. This BT and CT are the two most simple tests which are done routinely for every minor or major surgery, starting from the tooth extraction to biopsy procedures, or before or during any anticoagulant therapy. So that's it for today's discussion. I have completed my lecture on your physiology of blood and blood cells. If you have any questions, you can put it uh, into the comment box, or you can ask me here. Dr. Naik, I
Thank
hope
you.
I have completed in time.
You made it early.
Okay.
Thank you. Thank you.
Okay.
So I would like to suggest you, in
Yeah.
case you have nearly 20 minutes time, would
Yeah.
you like to explain few steps which are like for erythropoiesis, hemostasis, these two as well as the functions of WBCs? If you
Yeah.
can elaborate a little bit, that will be
Yeah.
good, I believe.
Yeah. I can go for the functions of WBCs. Uh, for neutrophils, as we went into phagocytosis and all. So, phagocytosis is a process in which the cell goes and engulfs the foreign material which is present. This phagocytosis process again is of two types: oxygen dependent and oxygen independent. So, it can go through any of that, and when it engulfs, when it takes up the material, the uh, inclusion which is formed is termed as the phagosome. This phagosome goes and unites with the lysosome and they form the phagolysosome. Now these lysosomes have lytic enzymes which digests those foreign substances or antigenic substances, whatever you can say. It's better to tell them non-self proteins. So, and then that is excreted out of the cell. It moves towards the cell membrane, fuses over there, and it is excreted out. Then for the function of the basophils, as I told that time, that it is of the type 1 hypersensitivity reactions. So what happens is when an allergen enters the body, it triggers the clone of B cells, which produces IgE antibodies. And when the amount of IgE antibodies reaches the threshold, these IgE antibodies go and bound to the FC receptors, IgE FC receptors, which are present on the membrane of the basophil cells and the mast cells. So it reaches the threshold level, and that causes a lysis of the basophil cells or the mast cells, and it releases the uh, granules, mainly the histamine granules. Those release of granules again can be divided into two portions as primary and secondary. And histamine being the main culprit over there, it causes vasodilatation and irritation, various inflammatory responses, as we know. The Ruber-Callard-Dallard process, it is triggered by it. So that is the role of basophils over there in type 1 hypersensitivity reactions. And then majorly we can go into monocytes. When it gets changed into macrophages, it behaves as APCs. Macrophages also has a property of phagocytosis, but means being a special person of immunology, I will give much more emphasis on its behavior as APCs, that is antigen presenting cell, where it takes up the protein or the protein part together with the cell membrane of the bacteria which enters. Again, you have two pathways, exogenous and endogenous, depending upon the source of the non-self protein which is coming into. And after processing, depending upon which pathway it has come from, it expresses with another set of proteins which are the MHC proteins, major histocompatibility complex. They are again of three types, but class 3, its function is still to be explored. Class 1 and class 2 is known, and taking from those two pathways, it is expressed via the class 1 or class 2. If it is expressed with the class 1, then it is going to trigger the T killer cells or the T cytotoxic cells, and that will go into a CMI response where the T cell itself goes and kills it and does the job. If it is via the class 2 MHC, then it goes for the T helper cells. Then there are two subsets of T helper cells, 2 and 3, 2 and 1, 2 being the B cell dependent ones. So that helper cell goes and does T cell B cell cooperation with the B cell. The B cell is activated and it is divided again into two: memory cell and plasma cell. Memory cell remains there for your secondary response, and the plasma cell goes on to produce the antibodies. Again, that
I hope
antibody I can go
our
on and on with it, Dr. Naik. So
no, no,
those,
no. That's what I want to tell that maybe our audience might be scared of your.
no. So I think I should stop it over here so this
No, no.
can
What I
continue. You know.
want to suggest that don't worry, audience. There will be separate class on
Yeah.
lecture on immunology. Separately, it will be taken. What I want to you to summarize the things like WBC, the immune part, the fighting part mostly. Then along with that, RBC, the oxygen carrying and
Yeah.
carbon dioxide carrying. So, what about the platelets, the vasoconstant, this
Yes.
hemostasis?
Yes. Actually,
If
for
you can go back to your slide and just a recapitulation of the these this part, that will be a good one, I believe.
this is the method of erythropoiesis which you were talking about.
Yes.
Yeah.
So just a recapitulation. These
Yeah.
are for UG students. These three four.
Yeah.
Uh,
So I think I will explain this slide once more because here, it's a complete summary.
yes.
Yeah.
That will be a good help for the
Yeah. Yeah.
audience, I
Yeah.
believe. And after this, if you can do the blood coagulation part once.
Okay. 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 Sure.
Blood coagulation is also there, isn't it?
Yeah. Yeah. It's there. It's there.
You have a composite slide.
Yeah. I have a composite slide with
Yeah,
the
these two
extrinsic
slides,
and
if you can,
intrinsic factors.
that will be a good recapitulation for the students, I believe.
Okay. 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 So this is erythropoiesis, as Dr. Naik told that let us recapitulate these two processes. So this is a process in which, see, it's written already that it is for RBC production and maturation, and it is mainly done in these two places where in bone marrow from the pluripotent hematopoietic stem cell it goes up to the reticulocyte, and this reticulocyte is released with the loss of certain organelles to the blood as matured RBCs. So these pro-erythroblasts, these are only termed as the pro-normoblasts. This goes into the intermediate normoblast, and this is the late normoblast, which it has been shown. See here from the figure only, you can see that this is a huge cell. This, and the dia of the cell gradually keeps on decreasing by the process of erythropoiesis. And the other thing which you should always remember is, see the size of the nucleus, it also keeps on reducing and finally it's gone. Okay. So, see here, the nucleus is huge. You have a very thin lining of cytoplasm over here. There are two or more than two nucleoli within it. It is a very dense portion and it becomes condensed. And finally, when it goes into the reticulocyte, see, there is no nucleus at all. And this loss of nucleus occurs by the process called pyknosis. Okay. And together with the loss of the nucleus, there are also loss of certain other organelles. As we told that a matured RBC does not have mitochondria. They cannot produce any proteins or lipids or anything as such. Okay. So there is a loss of those organelles, and the remaining few organelles which are also there loses before it comes into the blood. Moreover, see the color of the cell. See how it is changing. Here you have a purple stained cell and then suddenly it becomes red. Why does it do that? Because in the late normoblast, it is marked. That is the stage where your hemoglobin appears first. And see, when it becomes reticulocyte, it is completely red. That is, the pigment is there. Okay, that's why this is red in color. See here, it's written over here. See the synthesis, hemoglobin synthesis starts over here. So this erythroblast from here, it is basophilic. Here it becomes polychromatophilic, and then it is orthochromatic. Okay. So, and as because this reticulocyte is, the transit stage from the bone marrow to the blood, here in the circulating RBCs, about 1% of the circulating RBCs are nothing but reticulocytes. Okay, I hope this will recapitulate and help you to understand the process. And I can go into the slides of your blood coagulation once again. See here, you have two pathways, one intrinsic and extrinsic. See here, it starts with the collagen. Here, the factors of the blood coagulation cascade, this you have done in your classes, obviously. This is the factor 12, 11, 9, and 8. These are all cascade. Cascade is what? Is a waterfall. That means the above one, as it gets activated, it activates the lower factor which is inactive. This again, when it again activates the another factor which is inactive. This activates its lower factor which is inactive, and finally see both the pathways, they are coming into the factor 10, which with factor 5, with it is converting the prothrombin to thrombin. Okay, and this thrombin helps in the conversion of the fibrinogen to fibrin. This fibrin is your final clot, which is together with the platelet plug, it forms the clot over here. And now see, this clot shouldn't increase, but okay, if it increases and blocks the blood vessels, then it will in turn be it is going to create some problem. Okay, so then again, for that, nature has planned another enzyme, that is plasmin, which comes from plasminogen. All these enzymes, all these factors, they are always in an inactive forms, and only when they are required, they are converted into the active forms. That's the beauty of nature, actually. I think that's enough.
Yeah, thank you very much, Dr. Samanto. It's a fantastic one, and thank you again for recapitulating those primary major areas which are highly important. As you know, as a teacher, we emphasize these 2 3 points mostly for the
Yeah,
students.
yeah,
That you need to know about the erythropoiesis, you need to know about the blood coagulation, and the rest of the part, what you have mentioned, it's a fantastic one. It's a very good overview.
thank you.
Thank you very much for your time and the energy you have put into. It's
Thank you,
very
Dr.
good.
Naik.
Thank you from
Thank you.
the uh, uh, actually, your co-speaker also is saying superb lecture.
Yes, thank you, Dr. Anish. Thank you.
So I think you made his work little
Yeah,
easier. So
yeah,
its ground is ready, and really we wish to thank again, and maybe you will be with us. We will continue with the second lecture, and
yeah,
then at the
sure.
end, if we will see if any query comes. But mostly, we are expecting that there will be. This is going to be a synchronous as well as asynchronous. However,
Okay,
mostly it is asynchronous learning.
okay.
Students, they can uh, see these follow these lectures in their convenience.
And
That's
they
the
are most welcome. You can share my mail ID, my phone number, which is present already with you. You can share it. They are most welcome to contact me whenever they wish to.
sure. Thank you very much. Thank you very
Thank you.
much.
Thank you, Dr. Naik.
So we have had one beautiful lecture now with blood, what it is, and blood functions, then how the components of bloods they are working. Now we will be having our next speaker, Dr. Anish Singhal. He is Dr. Anish. I'm lucky in this. Before I introduce him, today's lecture, both these speakers are my juniors, very beloved juniors. Dr. Tanushree, she is from my college, where I did my BSc, and she is my from my hometown. And Dr. Anish, he is now in AIIMS Bibinagar, assistant professor there. And before he joined there, he was with us in Jodhpur, AIIMS Jodhpur, for 3 years. After that, he before joining here, he was working as assistant professor. So he completed his MBBS and MD from KIMS, Mangalore, isn't it, Dr. Anish? It's Mangalore.
Yes, KMC Mangalore. Yes, sir.
KMC Mangalore, and he is a great teacher, good teacher, young good teacher. Uh, to introduce him, he has nearly more than 7 years of teaching physiology to medical and paramedical UG as well as PG courses. Not only teaching, he is also a good researcher and also a good administrative. He was deputy medical superintendent for nearly 2 years, over 2 years at AIIMS Bibinagar. He has experience in clinical physiology in terms of intraoperative neurophysiological monitoring and autonomic function testing as well as cognitive testing. So in clinical physiology, these are the three fields coming up now. All these three fields, which are neurological fields, he had mastery in that. He had more than 20 publications and some book chapters also he has contributed. He is also got some awards, best oral paper, best outgoing PG, student scholarship, travel grants, good number. I'm not going to read all these things. I wish I give more time for uh, to the audience so that they can enjoy Dr. Anish's lecture. And Dr. Anish is going to talk about clinical implications, clinical importance of blood, clinical what I should usefulness. Sorry, somebody is doing some baji. Anyway, so Dr. Anish, I welcome you and
Thank you, sir.
please continue.
Sir, thank you, sir. Thank you so much, sir. So I'll just try to share my screen. Okay. Okay. Sir, are my slides visible?
Visible.
Okay. Right. So thank you so much, Nayak sir, for the sweetest introduction. And now I will start my topic on clinical implications of blood physiology. Before I start, I would like to thank the Society of India Education Committee for initiating this online lecture series and having me as a speaker of one of the sessions. So I understand that these lectures are meant to be for first year physiology students, but still, before having that bias in the mind, I assume post COVID we have understood a lot about blood and importance of so many tests in diagnosing and understanding the prognosis. So diagnosis is coming to a conclusion, what is the disease, which is the disease. Okay, and prognosis means to find out when you start a treatment whether the treatment is going on good, or what way the patient is heading to, that is prognosis. So we understand that there were so many tests or so many things that we should be aware of, irrespective of what our curriculum says, and even that applies to the layman, that they should know certain things, clinical aspects of those things. Okay, so I would thank madam that she has laid all the groundwork for me, and the things are very easy for me to take off now. Right. So you already know that blood has got four components, which is the red blood cell, the white blood cells, platelets, and the plasma. Okay. We understand that the most important function of red blood cells is to transport oxygen and CO2. Oxygen would be carried from the lungs towards the tissues, whereas CO2 would be carried from tissues towards the lungs, and then respiratory system will take over to throw them out. White blood cells, so we can say that RBCs are like trucks. In our body, RBC acts like truck which loads oxygen from the factory and gives it to the stores in the cells, right? And similarly, it loads CO2 from the cells and gives out uh, outside, right? So we will consider RBCs like trucks. WBCs are of various types, and each one has got its separate, most importantly in protection. They fight against the foreign infections or the invaders, and they protect our body from them, right? So as accurately madam has said, they are like the microscopic policemen. So they are the police. And we understand exactly same logic will apply when we see the clinical aspects. If police is less in the society, what will happen? The crime will increase. Similarly, your body would be more prone to infections. And if police is more, unnecessarily you have posted police, then they act against us. We will be caught more frequently, even for minor things we will be caught, right? So that also is a problem which would be immune problems. Fine. Third category of components is the platelets. Platelets are like bricks. When you have to construct a wall, or you have to create a dam, right? So you create a partition or a obstruction so that flow or leakage is not there. So platelet are like bricks, and the clotting factors in the blood, they are like cement. They help the platelet to stay in place. Fine. And finally, we have the plasma. Plasma, you all know, has got a very important role, not only with respect to the contents of plasma, what it has, as madam has told, crystallites, colloids, all those things. Okay, it also acts as the important function. It has that all those proteins inside, they help in storage and transport of hormones. Okay, plasma also helps in maintaining the volume of blood. So all the other things, maintaining the acid base balance, so all these things are the functions of plasma, right? So these functions can be broadly categorized in following headings: oxygen transport, carbon dioxide transport, hemostasis, immune responses, hematopoiesis. Forming these components is also a function of this blood system. Okay, so this will happen in the bone marrows. pH regulation and homeostasis in general, where you can talk about the hormone homeostasis, the blood pressure homeostasis, fluid balance, and the electrolyte homeostasis. Okay. The topic: clinical implication. Clinical implication, this term refers to the significance. Practically, what significance the existing knowledge or the medical text that we have, to that. It encompasses the real world applications, ramifications, or impacts of the particular understanding and the concepts with realm of healthcare and patient care. So, from clinical implications, we are trying to understand what is the applicability of that knowledge in diagnosing, treating, managing, and understanding the diseases or in patient care. Okay. So, to understand, diagnose, treat, or manage diseases from the basic knowledge of the blood physiology, we should be able to find out what is not the blood physiology, right? So by definition, physiology is the normal functioning. So if something is not normal, that has to be a abnormal thing, and any abnormality would be considered as a disease. So So each component can have its own set of diseases. So how we understand the clinical implications of blood is by first categorizing, classifying the disorders. Then in each disorder category or that particular disease, we should know what caused it, how it is manifesting, how to diagnose, how to treat, and per se overall management. So the content of my lecture would be some diseases and some techniques. Okay. Yes, as madam has already told you that if you are given a whole blood, one full bottle of blood in a test tube, and you have to find out what components it has, so this process is called as the PCV, the packed cell volume. Okay, what you do is you take this test tube and you centrifuge it, and after centrifugation, the simple principle of weight will apply. All the heavier objects settle down and the lighter objects float. Fine. So from there, we understand that our blood comprises of 45% of the red blood cells, 1% together white blood cells and platelets, and 55% of plasma with components of plasma. So these are certain normal values. Madam has already elaborated much on them. I would not go in much detail. Just have a look at it. So the hematocrit value, what I am showing here, is that PCV value, which means the percentage of RBCs in the blood. Now, coming on to our first set of disorders, which are the red blood cell disorders. So, you already know that the red blood cells have a particular size, 7.2 microns, right? And they have a very specific pigment in them, that is the hemoglobin. And the most important function of this pigment and red blood cell together is to transport oxygen and CO2, right? So as we can see here on the left side I have mentioned the functions of this cell, and on the right side I have mentioned most important disorders and the techniques that can be used, right? So knowing the basic knowledge of red blood cells, we know that first we will talk about the techniques part. How to find out how much is the normal number? So we use the CBC, complete blood count, and in that complete blood count you get the values for RBCs, you get the values for WBCs, and you get the values, differential values of the WBCs. Also you get the values of the platelets. Now in this you have to do the testing independently. For WBCs and RBCs you can use the Newber's chamber, and under the microscope you can calculate the number of red blood cells in a given area, right? Second thing is blood typing and cross matching. Blood typing and cross matching refers to the blood group part. As you know that the RBCs have proteins on their cell surface, and one of such proteins are the glycoprotein is responsible for us having a particular blood group. Okay, so this knowledge or the study to find out which protein is there on the RBC, it is blood typing. And blood cross matching refers to the process in which you find out the compatibility of the blood sample before you give that blood or you transfuse that blood to the recipient. Okay. Third thing is the serum protein electrophoresis. Here, what we do is we take the hemoglobin and you do the electrophoresis, or you take any sample where there is a mixture of lot of proteins. You do the electrophoresis, and you will come to know, because electrophoresis applies to the physical part, the heavy will settle down early and the lighter will go on till far. Third is the erythrocyte sedimentation rate. It is ESR common. It refers to the rate at which, if you on a vertical stand make the blood stand for some time, for 1 hour, and the heavy parts will automatically try to settle down. So this sedimentation rate of the red blood cells is calculated and is important for certain findings, especially during the inflammatory stages. And finally, it is some procedure is called as phlebotomy. In phlebotomy, it is different from blood donation, because in phlebotomy, what you do, you donate, you have to discard some part of blood if you have some disorders related to the red blood cells or hemoglobin, which make the human polycythemic. Polycythemic is exactly opposite to anemia. Now, let us start with anemia. The first disorder of RBC that I shall be discussing is anemia. Now, here you have to understand the concept of red blood cell indices. Now, if you take one cell, one RBC, so you understand that in that one RBC, it has got a volume and it has got some amount of hemoglobin, right? So the volume of one RBC is referred to as mean corpuscular volume. Okay. The content of hemoglobin in one RBC is understood as mean corpuscular hemoglobin. Okay. And overall concentration of hemoglobin in that percentage of RBCs, 45% of RBCs, is called as MCHC, mean corpuscular hemoglobin concentration. Okay. So this knowledge of having red blood cell indices is very important before we understand the disorders of the red blood cells. So the disorders of red blood cell, primarily they start because of the problem in the structure of the RBC, what we call as morphology. So either the red cell can be of normal size, or it can be smaller in size or higher in size. So by definition of mean corpuscular volume, we understand that if the volume or if the size of the RBC is higher, so it would be a high MCV. And if the red blood cell has got lower size or is a smaller in size, it would be a low MCV. Okay. So according to calculation from the MCV, you can classify RBCs into either normocytic if the volume is normal, or macrocytic or microcytic. So microcytic would refer when the RBCs are bigger in size, and microcytic when the RBCs are smaller in size. Okay. So this we can understand that if the truck, as we referred that RBCs are just like trucks, if you have got smaller trucks to transport say 100 boxes from one place to another, what will happen? So it is understood that if the trucks are smaller, the time taken to transport same 100 number of boxes would be more. Or you can imply that you can call for more smaller trucks, so that the number, if to you have to maintain the time, then you have to get more trucks to transport those boxes. So same things will happen, that if the size is smaller, the time taken for that supply of oxygen would be more, and in that response body undergoes erythropoiesis. Okay, certain factors, this hypoxia, this shortage of oxygen will stimulate erythropoiesis, and in that response more and more RBCs would be produced. Okay. Then one of the other causes, so what are the causes of microcytosis? Microcytosis can be because of deficiency of iron, or it can be because of abnormal globin chains, hemoglobin chains. Okay. Since the hemoglobin is abnormal, the RBC does not grow to that volume. Okay. So this is microcytic anemia. So in microcytic anemia, we can understand that the size is smaller, the time taken to supply oxygen would be more, there would be stimulation of erythropoiesis, and the commonest cause for this microcytic anemia is either iron deficiency or thalassemia. Second, macrocytosis. Now, if the truck is bigger in size, what will happen? The road size is same, but your trucks are unnecessarily bigger. What they do is they obstruct the vessels. There is congestion in the vessels. There is no free flow in the blood, so it becomes turbulent. Okay, and this macrocytosis also occurs during the increased number of RBCs in polycythemia. Okay. Now, in causes for macrocytosis can be, again, when there is less redness, hypochromic. It occurs when more and more RBCs are released in the bloodstream. So RBCs take, as madam said, 7 to 10 days of time to mature. So before the RBCs are matured and they are released in the circulation, so what will happen? A fully matured RBC will not appear, whereas just one stage before reticulocytes will appear in the bloodstream, and these reticulocytes are bigger in size. Another can be the factors which lead to maturation of the RBCs, they are not available. So in in liver disorders, vitamin B12 deficiency, folic acid deficiency, when these factors which are required for maturation of the RBCs and help to achieve their normal size, if there is the deficiency of these factors, the RBCs won't reduce their size during maturation, and those bigger sized RBCs are released in circulation. So this is macrocytic anemia. Normocytic anemia, the size is normal, but somehow there, because of some reasons, the RBC is not able to transport oxygen properly. Now, when we have understood that the RBC disorders are based on the volume, okay, so MCV high, that means RBC is big, MCV low, RBC is small, okay. But what do you mean by anemia? Anemia is either with same number of RBCs or lower number of RBCs or low hemoglobin level leading to decreased oxygen transport. Okay, so the cells do not get sufficient oxygen. So in all these disorders, ultimately you will be having hypoxia. Hypoxia means low oxygen delivery to the cells. Now, in this slide, I am trying to show, see the blue arrow, there you get to see a big RBC. Whereas just on the 4 o'clock position to the blue arrow, you can see a normal RBC. And again on the 4 o'clock position to the normal RBC, you see the black arrow, it is a microcytic RBC. So this slide is important to understand how a normal RBC is there. On the right side, you can see a microcytic RBC. On the left side, you can see a macrocytic RBC. So just to see certain in-depth, iron deficiency anemia, the most important cause is nutritional deficiency. We are a developing country. Many of the people do not have sufficient resources to have a balanced diet. So this nutritional deficiency causes you to take low iron in the diet, and this leads to the development of iron deficiency anemia. The signs and symptoms are absolutely typical. So if your body is having anemia, that means your body is not able to deliver sufficient oxygen. So you feel fatigued, you do not feel enthusiastic, there will be less redness of the blood. Since blood is less red, then you get pallor, and weakness is a general symptom because of hypoxia. And how will you diagnose anemia or deficiency anemia? First, logically, you have to go with the complete blood count. In that, you might find that RBCs are low, okay, or you might find the hemoglobin MCV, MCH are low, right? So if those are the causes, then you have to treat accordingly. If you get that in MCH, that the hemoglobin concentration is low in the blood, in the RBCs, then you go further for the iron studies, the serum ferritin and those studies, to understand that whether it is truly a iron deficiency anemia or any other kind of anemia. If in the complete blood count you get that MCV is more, the volumes of the RBCs are more, then your most likely diagnosis will go to the second point, which is the deficiency anemia, where you can assume your differential diagnosis can be, it might be either because of deficiency of vitamin B12 or folate. Okay, the signs and symptoms remain same, and for confirmation you need to do the levels and serum folate levels. Third kind of anemia can be the hemolytic anemia. So in hemolytic anemia, what is happening is hemolysis. The blood is getting destroyed, the blood is being broken. Okay, so what happens is, because the blood breaks or there is lysis of the RBCs in the blood, this leads to release of hemoglobin in the blood, and this hemoglobin gets converted into bilirubin and gets deposited everywhere in the body, right? So this is called as jaundice. This, since bilirubin is yellow in color, you get yellowish discoloration and you will see jaundice. And those broken RBCs would be scavenged by the spleen, and the work of spleen is increased, so the spleen enlarges. Fine. So how do you understand this? Again, CBC, because of hemolysis, because of breakdown of the RBCs, there would be low number of RBCs present in the blood. And then you can see a peripheral blood smear where you can see the differential counts of the other cells, that will be normal, whereas the RBCs would be seen as broken ones, right? To compensate for this loss of RBCs, body will try to release more and more RBCs, increase the hematopoiesis, release more immature RBCs in the blood. So you will see the reticulocyte counts to be increased. Next, the abnormalities of hemoglobin. You have a variant called as hemoglobin S, which is responsible for the sickling trait. Okay, it is also called as the sickle cell anemia. It has got a genetic cause where the gene for hemoglobin production is altered, right? The amino acids are changed, and this will lead to the development of anemia whenever exposed to a stressful condition where there is low atmospheric oxygen. How will you confirm this? You have to get the hemoglobin electrophoresis done, and then you will understand what kind of hemoglobin is there. As madam has already shown you, the normal variants of hemoglobin for adults is hemoglobin A, right? So instead of hemoglobin A, you will find hemoglobin S in the electrophoresis. So this is a complete algorithm. You get a blood sample, and now you have to find out what's happening with that. So what we do first, we will take the blood sample, right? We will see the PCV, how much is the red cell volume. Fine. So 45% should be normal. Then you will do the CBC. In CBC, you will find out the absolute numbers of each component of platelets, of WBCs, and of RBCs. Then in the RBCs, you run the blood cell indices, red cell indices. Then you will get the values for MCV and MCH. Based on the MCV values, you can find out whether it is a microcytic anemia or a macrocytic anemia. If it is a microcytic anemia, you go for iron studies. If it is a macrocytic anemia, you go for serum B12 and folic acid study, right? If none of these are there, then you go for HB electrophoresis to find out other causes leading to microcytosis. Okay. Then in HB electrophoresis, if there is any abnormality in the hemoglobin, you can particularly find that variant of hemoglobin, and you will get the diagnosis of those diseases. So this algorithm runs in a very logical way and is very simple to understand. Don't get scared just by seeing it. Next, so this was anemia. Now we are moving on to the next clinical implication in the red blood cells. Here we would be talking about jaundice. So you know that in routine also, the fate of red blood cells after the 120 days, the red blood cells would be broken down, the RBCs would be removed by the spleen, whereas the hemoglobin is again reutilized. Okay. So but if in routine also, if there is more hemolysis for whatever reason there might be, what will happen? This heme part will be converted to biliverdin. This would be taken up by the liver. In the liver, the most important enzyme would be UDP, glucuronil transferase, and it converts this unconjugated bilirubin to conjugated bilirubin. This is then stored in the gallbladder, and from there it goes to the intestines, and enterohepatic circulation is responsible for utilizing it again. Some part will be excreted in the feces as stercobilins, and some part would be excreted in the urine as urobilins. Fine. So if this is the problem, then what happens? Before the liver stage, if there is hemolysis, more breakdown of RBCs, that can lead to increased concentrations of unconjugated bilirubin. So this is called as unconjugated hyperbilirubinemia, and this hyperbilirubinemia will cause yellowish discoloration in the skin and mucous membrane. If the cause is absence of the enzyme UDP glucuronil transferase, so there would be less conversion of unconjugated to conjugated. Again, the conjugated would get deposited, and this will be again a type of a unconjugated hyperbilirubinemia. If the cause is blockage in the duct that transports the bilirubin from liver towards the intestines, if that duct is blocked because of the gallstones or other stones, then that leads to obstruction in the outflow. What will happen? The conjugated bilirubin starts getting deposited, and it spills over everywhere in the body, and yellowish discoloration again is seen. So the sign and symptom would be yellowish discoloration and itching. But when you find out the cause, you can do the enzyme assay for finding out that enzyme, whether it is deficiency or not. Then accordingly you can find out which one was increased. Unconjugated, then you suspect hemolysis or deficiency in the enzyme. If it is conjugated, you suspect a gallbladder. For gallbladder, with the USG, you will know that. And if it is unconjugated, you can do the CBC and understand whether there is hemolysis or not. So this is what I have just explained. So prehepatic is nothing but the jaundice caused by the hemolysis. Hepatic is the jaundice caused by the absence of enzyme, and post-hepatic is the because of the obstruction. Coming to the next part in the red blood cells, a most important thing, one of the most important thing on red blood cells is the antigen or the protein that detects our blood group. Okay, we commonly follow the ABO blood grouping system. There are other blood grouping systems also. So in ABO blood grouping system, we understand that either the blood group can be A or B or AB or O. Okay, so and with the presence or absence of the Rh antigen, it can be positive or negative. So we have to understand this important clinical implication of blood group antigens. So blood grouping refers to the finding out of the blood group of the individual. Why we need to find out the blood group? Because there are instances or there are events where that person might have a need to receive blood, or might have a chance to donate blood to someone. So we have to know the blood group antigen. Otherwise, if it is not the same blood group, then that blood acts as a foreign body in the recipient's blood, which leads to immune reactions. Your WBCs will go there and fight against that RBC and make it hemolyzed. Right? So with this chart, you understand that O blood group means neither there is A antigen nor B antigen. Okay, so this absence of any antigen is a good thing, because when you give RBCs of such a person to any other person, there, since there are no RBCs, there is no antigen, the immune response of the recipient will not detect any antigen, and since there is no antigen, the blood is accepted. Okay, so this is a general understanding that since O blood group people do not have either A antigen or B antigen, they are the universal donors. Fine. That also O negative, because they do not have the Rh antigen also. Okay, so similarly, if the donor is O positive, you can give blood to AB positive, A positive, B positive, or O positive itself. You cannot give this blood to any person with the Rh negative status. Okay, similarly, we can understand the other blood groups also, that only AB positive is the one who can give blood only to another AB positive. So it is but can take blood from anyone. So O negative is the universal donor and AB positive is the universal recipient. AB positive can take blood from O negative, can take from O positive, B negative, B positive. So it becomes the universal recipient. Now, so once we find out group of a person, it is blood group typing. Now, before giving blood, transfusing blood to any other person, we have to do another test that is called as cross matching. Cross matching involves two types. One is called as the major cross matching, another is called as the minor cross matching. In major cross matching, you test the RBCs of the person with the plasma of the recipient. Okay, the RBCs of donor and the plasma of recipient. Why this has to be understood properly is because you should know that the antibodies are present in the plasma. Okay, whereas the antigen is present on the RBC. So if you have chosen a donor, you will that donor will have antigens on the RBCs, whereas the reaction would start from the recipient's plasma where the antibodies are present. Now, as per the Landsteiner's law, it is very well known to us that a person with a particular antigen will not have antibody to that same antigen, but will have antibodies for the other antigen. So if my blood group is B, okay, my blood will not have antibodies for B, but it will have antibodies for A antigen. Okay, so I can have a blood transfusion from a B person but not from a person. Now, we also have to understand that in the major cross matching, you will understand that if the person is O negative, okay, that person RBC is not having any kind of antigen, so it can be easily accepted by the recipient's plasma and blood transfusion takes place. Now consider the another type of cross matching, which is called as the minor cross matching. In minor cross matching, you take recipient's RBCs against the donor's plasma. Fine. The interesting case again is the O negative person as a donor. So O negative person, based on the Landsteiner law, we understand that since it does not have any antigen, it will have antibodies for all the antigens. It will have anti-A, anti-B, and anti-D. So how can O negative become a universal donor when it will not accept the minor cross matching? Because this blood, if you give whole blood of the donor, of O negative donor to any other person, the minor cross matching will show agglutination. Okay, but still they are considered as universal donors. That is because the plasma in the transfused blood is almost 50 ml, 50 to 100 ml maximum plasma is given, whereas plasma in your body is approximately 2.5 to 3 liters. Okay, so that 100 ml of plasma which is not matching with 2.5 liters gets diluted, and that effect does not manifest. Okay, coming to the algorithm. So if you get any blood sample, first you type for what blood group it is. Of both, you should test for the recipient who is donating, donors also, and the person who needs the blood, recipients also. Then you perform the antibody screening test. Okay, and the matching, cross matching, so which blood is compatible with the another blood, and accordingly you can issue the blood products. So in this, we also have to understand that it is not only that always we give the whole blood. Whole blood means we are giving plasma, RBC, and other cells, everything of the donor to the recipient. Only RBCs can be given. Okay, only platelets can be given, only plasma can be given. So like that, you can break down the blood into various components, and accordingly transfusion as per need can be done. If there is a carelessness or any technical problem due to which the after transfusion there has been a development of transfusion reaction. Okay, so transfusion reactions can be acute. Acute means immediately occur during the transfusion, or delayed during after the transfusion has already taken place. So these two types of transfusion reactions are there. And to summarize these transfusion reactions, you can see this slide, where whenever you donate blood, the recipient usually does not have any reaction. Okay, but there can be itching, there can be development of fever or chills, there can be hypotension, or there can be difficulty in breathing, that is dyspnea. So if there is itching, so it is understood that there has been some allergic reaction inside the body after the recipient has received the blood. If there is development of fever, then it might imply that either there is a febrile reaction, or there has been some infection that has, the blood sample may be contaminated or infected already, and that infection has passed on to the recipient. There can be hypotension. Hypotension can be because of the immune reaction leading to hemolysis, or any other anaphylactic reaction, allergic reaction. Or there can be dyspnea. Dyspnea in difficulty of breathing. You have given transfused more blood to the recipient, which increased the blood volume in the recipient, and that increased blood volume is leading to edema everywhere. So see this algorithm again. Don't get scared by just seeing it. Now if you get any, whenever you are transfusing blood, okay, and you get any of these signs and symptoms, immediately follow these steps. First, stop the transfusion immediately. Fine, open a IV line, then confirm whether the products that you have given were correct. Fine, and then see for the symptoms what the patient is showing, whether there is fever, whether there is no fever. Okay, whether he is in respiratory distress or not in distress, whether there is hypotension or not. Only three things have to be seen. and accordingly you can come to a diagnosis, and of those diagnosis you have a specific treatment which is shown in the boxes below. The scope of our discussion, but for future you can refer this slide. Now, coming on to the WBC disorders. So till now we have finished the RBC disorders. Now we are coming on to the WBC disorders. Very easy to understand. WBCs are our policemen. So if you have low policemen, you are prone to infections. If you have more policemen, you are prone to autoimmune reactions. Right? So the most important problems with the WBCs in their numbers, that is called as leukemia. When there is a excessive more than 30,000 count of the WBCs, you get leukemia, right? And this is because of the genetic mutations leading to this cancerous condition. Okay, this can be acute or chronic. It can be in the lymphoblastic series or it can be in the myeloid series. So it can be acute lymphoblastic leukemia or chronic lymphoblastic leukemia. It can be acute myeloid leukemia or chronic myeloid leukemia. Okay, so these are the cancerous conditions or which commonly blood cancers. The signs and symptoms are vague, but there is very high chance that you will be more prone to infections. Fine. And then the diagnosis, most important diagnosis is the absolute WBC count, where you will see that the counts are more than 30,000, and you can confirm it which cells are more by doing the peripheral smear differential leukocyte count. Then you can confirm by getting the marrow biopsy. In the marrow biopsy you will get the ratio would be altered of the myeloid series, and you can confirm. Next, when the police are low, then what will happen? If there are no police, there will be development of immunodeficiency disorders. HIV is a very known topic to us, right? In that, what happens because of that virus, we end up in a low WBC state. Okay, and because of that low WBCs, we are immunodeficient because our immune cells are not available. Okay, so it can be a primary immunodeficiency or it can be a secondary immunodeficiency. In primary, where the cause is particularly related to or because of our own genetic makeup. So it can lead to B cell deficiency, T cell deficiency, combined deficiency, problems of the complement system, and the problems in the phagocytosis, because if neutrophils are very low in number, then phagocytosis will not occur, and phagocytosis being the first line of defense against any infection or invasion, that will affect. Okay, coming to the second set of the next set, which are the platelet disorders. Now again, there is something that we have to understand in the platelet disorders, because as I have already told you, platelets are like bricks. Okay, we need platelets for building or to avoid the leakage of blood. Okay, so the most important function platelets that do are the hemostasis, and the problems that can be there are low platelet count. Okay, or platelet count is normal, but we do not, the platelets are not functional. Fine. So if you call it thrombocytopenia, it is low platelet count, and thrombocyto asthenia, then it is abnormal platelet functioning. Okay, so if it is thrombocytopenia, it leads to a condition called as purpura. In purpura, what happens is the person is easy to bruise. There are particular hemorrhages, small red dots would be there all over the skin. Okay, especially if you increase the pressure, you hold the person very firmly, it may lead to bleeding situations. Okay, so it can be immune splenic purpura, or it can be drug induced. So drug induced becomes the secondary thrombocytopenia cause, and the immune would be primary. Fine. Confirmation is again done by finding out the platelet counts. Next, coming to the plasma disorders. Plasma has got a varied roles. Okay, so since it is involved in hemostasis, as plasma contains the clotting factors, plasma has got the important function of pH regulation, as it has got the complete set of bicarbonate system, right? right? Most important place. And then plasma plays a very important role in homeostasis, where being available, plasma just by being available helps in maintaining the blood volume. Okay, so it is hypovolemia or hypervolemia, it will be important to see the plasma volume. Okay, and since the if the volume is maintained, the blood pressure is also maintained. So just presence of plasma is very important for the cardiovascular system to have a normal pressure. Now, the diseases in plasma can be low clotting factors, abnormally low amounts of clotting factors. This causes the forms the basis of clotting disorders. Most important clotting disorder is hemophilia. Now, one Willebrand's disease, I have mentioned it here, but because the factor is present in the plasma, but one Willebrand's disease causes bleeding time to increase, which is with the platelets. Now, we have to understand, before we understand the bleeding disorders and clotting disorders, we have to understand what is bleeding time and clotting time. And before that, you should have a understanding of the how the hemostasis occurs. Okay, as madam has already told you, if there is any reason for bleeding, the first step would be the platelets will go there and make a temporary brick, okay, brick like situation, and stop the bleeding. Then the clotting factors will go there, surround the platelets, and make that plug, hemostatic plug, as a permanent plug. So the first time, which is from onset of bleeding to the formation of temporary platelet plug, okay, this is called as bleeding time. And the time from bleeding to formation of the permanent structure with the help of the clotting factors, that is called as the clotting time. Now, if there is any problem in the platelet function or platelet aggregation, this forms the basis for bleeding disorders. And if there is problem in the formation of the permanent hemostatic plug, which is with the help of the clotting factor, the clotting disorders. Okay, so hemophilia is a clotting disorder because hemophilia is caused by the deficiency of clotting factors. Okay, whereas von Willebrand's disease is a type of a bleeding disorder because von Willebrand's disease, in that there is deficiency of von Willebrand's factor that helps platelet to accumulate there, aggregate there. So in von Willebrand's disease, there would be increase in bleeding time, whereas in hemophilia, there would be increase in clotting time. Now, plasma has got various plasma proteins. Okay, so these proteins, as already has been told, albumin, globulin, fibrinogen, and prothrombin. So you can do a electrophoresis and see the amount and concentrations of various types of proteins present in plasma. Since plasma has got so many proteins, plasma never forms a good substance or a good sample for proteomics studies. Okay, transcriptomics and proteomics studies, plasma is always considered as a bad sample because there is a lot of other proteins present and which might affect the outcome of your study. Now, this is a simple table in which you can see different disorders related to bleeding. Okay, so the first, from the left I am starting, you can see the problem can be in the vascular system. Okay, if the blood vessels are not proper, which are causing bleeding, okay, there is no dysfunction of platelets or there is no dysfunction in the clotting factors, you will have the normal bleeding time and the normal clotting time. And the problem is in the vascular system. In the center, you see the problems are with the platelets. Okay, now if the platelet is not functioning properly, we already have understood that it will cause a increase in the bleeding time. Because platelets are not normal or platelets are low in number, what will happen? They will take time to make the temporary hemostatic plug, because of which the bleeding will continue, and this will give us the indication that bleeding time has increased. Okay, on the right side, now you see, if there is deficiency of clotting factors, what will happen if there is an injury? Okay, the bleeding will occur. Since the platelets were normal in function, the bleeding will stop immediately. Okay, but if you give a little bit of more pressure, the bleeding will restart. There is no permanent hemostatic plug formation in the absence of clotting factors. So this is assessed crudely by the clotting time and more accurately by estimating the prothrombin time or the partial thromboplastin time. Now, what is prothrombin time? In your coagulation cascade, in this coagulation cascade, you have understood that there is an intrinsic pathway and there is another pathway, extrinsic pathway for permanent hemostatic plug formation. So based on the injury, if the injury is was open, the outside factors entered the blood vessel, then the extrinsic pathway would be followed. And if the problem was inside the blood vessels itself, the intrinsic pathway plays the role for coagulation. Now, prothrombin time is the time where you assess the from the injury till the stoppage of bleeding, when you are seeing the extrinsic pathway. How to remember this? That prothrombin time implies extrinsic pathway is that you can remember the mnemonic play tennis. Okay, tennis is played outside. Fine. So prothrombin time extrinsic pathway. The another one is partial thromboplastin time. Partial thromboplastin time, you can remember the mnemonic play table tennis. Table tennis you will play in a closed environment. So partial thromboplastin time will reflect the intrinsic pathway. So this information is needed to exactly identify what is the problem. So if you get a blood sample and your PT is normal, but your PTT, partial thromboplastin time, is abnormal. So what is your understanding? The understanding, it would be that the problem should be in the intrinsic pathway. And since the intrinsic pathway has got the factors F12, okay, factor 11, factor 9, factor 8, so you will keep on thinking, okay, these factors might be deficient. Okay, so which PT or PTT, which parameter is increased, accordingly you can try to localize the flaw where the problem is, and then accordingly treat the person. Okay, so this chart gives in detail the same thing. Coming back to our this slide. Yeah, so the next thing is hemophilia. Now hemophilia, as I have already told, it is a clotting disorder. Okay, now in hemophilia A, it is because of the factor 8 deficiency, whereas hemophilia B occurs because of the deficiency of factor 9. Now, as per our this knowledge, you can understand that factor 8 and factor 9 both are in the intrinsic pathway. Okay, so in hemophilia patients, you will see an increase in PTT. So PTT would be raised, whereas the prothrombin time or the PT will be normal. So it becomes very easy to diagnose if we know the exact system, right? Now, in von Willebrand's disease, as I've already told, von Willebrand's factor is deficient, and von Willebrand's factor is required for platelets to adhere on the blood vessel and then aggregate, right? So it leads to the abnormal bleeding time, whereas the clotting time shall be normal. So if you get any sample, the algorithm will tell you how to deal with it. First, do the screening studies, then you can get the blood clotting and blood clotting timings, right? And accordingly, you can find out the diagnosis and treat. So this is all from my part.
Thank you, Dr. Anish.
थैंक यू सर. आई होप इट वाज नॉट ओवर. आपने कई बार एक्सप्रेस किया, ज्यादा हो जाएगा, बट
It quite.
ओके.
No, maybe for the recapitulation it will be good, but I think for first year it is a little high. First year they don't
Sir,
go this
maybe they can when they go to the
diagnostic
second year, they can
again.
they can revisit the slide.
They can, they can.
Yes, sir.
And another thing, we need to apologize that the video from your side, it is coming as with some pauses. So
Oh.
there are some network glitches as you have expressed earlier, but we couldn't
Mhm.
rectify it unfortunately. We're
Mhm.
sorry for that. There are little glitches, few seconds, like maybe a small glitches were there.
Acha.
Anyhow, very good, very good. It's a very good presentation, and it was nice to see that things were uh, both both of you have done a great job. It's a big topic, very big topic. Beginning itself of the time we incepted this topic, we were afraid that how to
Yes.
manage these big topic, and
Yes.
as we can see, things you have managed it nicely. But as appreciated, as apprehended, that it is little over it has to be there is no other option to make it in a short video, 1 hour video. It's really tough. It's almost 17 18 lectures we are condensing in 2 hours, maybe more than actually you got
Yes, sir.
into the portions you have told. It's a hemopathology, quite hematology part. So it was quite condensed. I hope students can be benefited with these condensed views. Let us see how we get their views. I don't know if there are any questions. Let us check if any questions. No, as such, no question yet. So
And
if
my email ID I have already displayed on my first slide.
okay. So if there are any queries, if it is coming to us, we can transfer it to
Yes, sir.
you. We will and will be helping the students to understand if they find any difficulty any at any time. So as we are
Yes, sir.
repeatedly mentioning, this series is targeted with a view of asynchronous as well as synchronous. So those who have attending live, very few though, those who are attending live, they don't have any question yet, and but if any question comes from this, that will be. But you have done a splendid job. It's a very good overall view, and you have given the mnemonics also. uh, just check these tables. All these are like it can be shared. No issue,
Yeah.
no copyright issues
No, no,
or
no problem, sir. No problem. Yeah.
okay. That's good. So thank you very much. Thank you very
Thank you,
much.
sir.
It's really very good. Both of you done a great job, and thank you for
Thank you, sir.
your time and energy. I understand that you are not at your home. It's like away from home. Still, you have taken this responsibility. So it's nice. Thank you very much.
Thank you, sir. Thank you for inviting.
And thank you. We have in our background these videos are being brought to you by Dr. Sampa Viswas and Dr. Vinay Cheturi. Thank you, Dr. Vinay and Dr. Sampa. And thank you those who are viewing this. We'll be happy to get your feedback. So finally, before we conclude, we would like to announce that the next session of this PSI lecture series will be on digestive system, and Dr. B. Sirisa Kalyani from NRI Medical College, Guntur. She will be talking about the overview of the digestive system, and the second part will be by Dr. Arjun Maitra from Sri Ganganagar. Uh, he will be talking on the gastrointestinal movements. So hopefully we'll be meeting again. Before that, we have an announcement that we are going to celebrate Dr. Sir Upendranath Brahmachari's 150th birth anniversary on 19th. I think he just yeah, 19th December 2023. This year, 19th December, 7 p.m. 150th birth anniversary celebration of Dr. Sir Upendranath Brahmachari, and there will be a lecture on his life and his science. Sir Upendranath Brahmachari, his life and his science, by Dr. Kaushik Bharati on 19th December, evening 7 p.m. Thank you. Thank you very much for being with us. Thank you all.